A very good morning to one and all present here. My name is Dr. P. Sayarchana, reader from Oral Medicine and Radiology Department from Chetna Dental College and Research Institute, India. Today I'm going to present a topic called obstructive sleep apnea, a dentist perspective. According to American Academy of Sleep Medicine, obstructive sleep apnea is a serious condition that is characterized by repeated episodes of complete or partial obstruction of upper airway. Apnea means without breath. Apnea is defined as a cessation of airflow during the sleep which can last for at least 10 to 15 seconds with oxygen desaturation of more than 3% and or associated with arousals. Since this is a potentially fatal condition, this has to be diagnosed early. The management of OSA follows a multidisciplinary approach, and the role of dental professionals play a vital role in screening, referral, and treatment. The prevalence of OSA in urban Indian men ranges from 13 to 19.5%. OSA can be classified into central, obstructive, and mixed type, and can be graded into mild OSA if the AHI score is from 5 to 15, moderate OSA if it's ranging from 15 to 29, and severe OSA more than 30 episodes per hour. The cause for obstructive sleep apnea are when the throat muscle relaxes and blocks the upper airways during sleep. The risk factors are obesity, narrowed airways, high blood pressure, chronic nasal congestion, smoking, diabetes, gender variations, genetics, and asthma. Whereas the causes for central sleep apnea are when the brain doesn't send proper signals to the muscles that control breathing, and the risk factors contributing are congestive heart failure, hypothyroid, kidney failure, neurological diseases, and damage to brainstem. Now, when it comes to the mix it will be a mix of both. So, features of both central and obstructive sleep apnea will be present together. The etiology causing the obstructive sleep apnea are as follows. Obesity is the main predisposing factor for OSA. Other factors will include craniofacial abnormalities like micrognathia and retinognathia. Age, mostly the middle-aged people will get mostly affected. Male gender is more prone. Genetic predispositions such as TNF factor alpha 1, PGE2, EP3 subtype are certain genes which predispose them to OSA, and consumption of alcohol, smoking, and sedatives also. The pathogenesis of OSA occurs due to inadequate motor tone of the tongue and or airway dilator muscles. In OSA, increase in airflow velocity to compensate reduced airflow causes vibrations of soft tissue leading to snoring. A detailed history has to be taken from the patient and also from the partner who is sleeping along with the patient has to be elicited. Symptoms like disruptive snoring, witness apnea by the partner, choking while sleeping, excessive daytime sleepiness, difficulty with concentration or short-term memory loss, excessive nocturia, difficulty with sleep maintenance, restless sleep, decreased libido, morning headaches, and irritability has to be asked. And the comorbid conditions like resistant hypertension, recurrent atrial fibrillation, stroke, myocardial infarction, pulmonary hypertension, and chronic heart failure should be ruled out. A thorough physical examination has to be performed on the patients, and ruling out of obesity, which is the major predisposing factor to OSA, has to be ruled out, and larger neck circumference more than 42 centimeters in men and 37 centimeters in women may contribute to the presence of OSA. There also be high arched palates, nasal deformities, and micrognathia. OSA. The symptoms are here separated into daytime and nighttime, whereas the intraoral manifestations are the presence of dry mouth, attrition, macroglossia, enlarged soft palate and uvula, and enlarged tonsil and adenoids. And the malocclusions ranging from class 2 to class 3 predispose the particular person to OSA. Mallampati class 3 and 4 are more prone to OSA. There are various questionnaires used for screening of OSA. Some of them are Epworth, Stop-Back, and Bury. Coming to the diagnosis of OSA, polysomnography serves as a gold standard for diagnosing OSA. Polysomnographic test reveals more than 15 predominantly obstructive respiratory events per hour or more than 5 predominantly respiratory events per hour and at least one of the following, that is daytime sleepiness, waking up with breath holding, gasping or choking, observed loud snoring, breathing interruption or both, hypertension, cognitive dysfunction, ischemic disease, congestive heart failure, or type 2 diabetes mellitus. This drug-induced sleep endoscopy is used for direct assessment of upper airway obstruction in the identification of OSA. This is the latest simple test for the screening of OSA, which can be done at home. Now, knowing the etiology and pathogenesis of OSA, treatment is needed. The treatment of OSA includes lifestyle changes and NIV, non-invasive positive pressure ventilation, MAD, that is the mandibular advancement devices, surgical options, and others. The NIV acts as a pneumatic splint to open up the collapsed airway. This is the CPAP device. MAD, a mandibular advancement device, helps to modify the position of jaw, tongue, and other supporting structures of the upper airway for treatment of OSA. These devices helps to open up the airway by moving the base of the tongue forward. This appliance can be inserted before sleep and removed in the morning. It helps reduces the lapses in breathing during the night and reduces the volume and the snoring frequency. How to prescribe MAT? MAT treatment protocol should only start after a thorough medical evaluation based on standard clinical, physical, and polysomnographic parameters. A careful candidate selection must be carried out by the sleep specialist as well as the qualified mat provider in order to achieve a greater therapeutic success. Indications of mat devices are those patients who cannot tolerate CPAP therapy or who are at higher surgical risk and can be recommended for cases from mild to moderate OSA. These are the few examples of FDA approved mat devices. Tongue retaining devices or stabilizing devices. These devices help the tongue move forward and it is intended to keep the tongue base from blocking the airway. The contraindications of the tongue retaining devices are nasal obstruction, periodontal damage, and occlusal changes. Then comes the mouth guards. The mouth guards are similar to the mandibular advancement devices, except which it's a temporary fix for OSA. The rapid maxillary expansion or the RMEs are considered for mild to moderate OSA. They can be given post-surgery while removal of tonsils and adenoids and in children who have a narrow arch. These rapid maxillary expansion devices are useful in opening the airway by expanding the roof of the mouth and it has to be worn throughout and not just night. These functional mandibular replacement devices helps to change the position of the hyoid bone towards a more forward position. In this type of appliance, both the maxillary and the mandibular component are treated simultaneously and is FDA approved for treatment of streak-related bruxism and OSA. These are the images. The other treatment options for treating OSA are nasal strips, throngs, electric anti-snoring devices, and liquids which are claimed to reduce the incidence of OSA, but not much studies are there to ascertain its sensitivity. The surgical treatment recommended for OSA is uvulopalato-pharyngoplasty, upper airway stimulation, and jaw surgery. Criteria of selection of patients for surgery is failed CPAP therapy, moderate to severe obstructive sleep apnea, and has a BMI of more than 30. In this orthognathic surgery, the upper and lower jaw are moved forward compared to the rest of facial bones to create space. Maxillary leaf-fold 1 osteotomy and the bilateral mandibular ramus surgical split osteotomy are the ones recommended for treating OSA. This is the pre-op and post-op picture, and there is 86% success rate in treating moderate to severe OSA patients. Hence, in conclusion, it concludes saying that OSA is a silent killer, and awareness about this life-threatening condition must be made aware to the public to prevent significant morbidity and mortality. It's a dental surgeon's responsibility to know the diagnostic parameters, the established definitions, and the limits of his field of work when working as a part of the multidisciplinary teams that monitor and treat respiratory sleep disorders. These are my references. Thank you.